And Stephanie, if I can come to you, how are PCM trials specifically supporting families through this process? So when they come into a trial and they're going to be engaging with mobile research nurses, how are you supporting them in that process?
Sure, absolutely. So we're primarily at the offset working with the sites and the sponsor to ensure that we are providing that information so that conversation can happen when they're being consented and make them aware of, okay, we understand this is a 2-year trial, but you'll only have to come to site for the year 1 and year 2 visit. Everything else can be done at home, and kind of assuaging those participant fears at the offset. We also train all of our sites on how to answer questions from participants if they're a little bit hesitant about mobile research for all of the reasons you noted. If they are saying, well, I'm not sure I want someone coming into this safe space, how much space would I have to give this person? What is that burden looking like? We coach the sites through that, and our nurses are also coached for how to address those concerns with those participants. And so we're very adamant about communication and being very transparent about what it will look like, and making it very clear to the participants and their families that we are doing everything we can to make this as easy as possible for you. We're not looking for a lot from you in order to move this forward.
Are things like data protection and privacy and security concerns for people? Obviously with files moving to the home environment and coming out of clinical settings, is that a concern for people that they ask questions about?
Absolutely. I think it's something that we do a good job of heading off. So we ensure that for PCM trials, that in the informed consent that outlines mobile visit services, that we also explicitly outline all of the data privacy information and how PCM trials will be utilizing it, so that that's all addressed at the offset and no one has to go fishing for any of that information.
Brilliant. And then by extension of that, how are the nurses, what extra training are they required to have in order to help move that process into these mobile situations? Is there unique facets that they need to cover that are a bit different that they need to be trained for?
Absolutely. So for PCM trials, we really have 2 primary buckets of training. We have one initial training when a nurse is being onboarded to PCM trials, where we train them on basics of research and GCP and things like that, and how that's adapted to a mobile setting, and how you need to be cognizant of all of those requirements in a mobile setting generally. And then before they're onboarded to any specific trial, we provide study-specific training that has been reviewed and approved by the client, to ensure that all of those visit procedures are appropriately adapted to the mobile visit setting, as well as providing a lot of education about the patient population and what you can expect when you're going into their space. As Ellen noted, with certain indications, there are people who will have different reactions to different things, and you have to be aware of those social situations to ensure that you're providing the best care possible. And so we coach all of that specific to each patient population.
And I'm interested as well whether it's a bit more intimate, suddenly somebody being in your home. Are your nurses kind of finding that then sometimes the patients are maybe offloading or perhaps being a little bit more emotional, or is it a different relationship than it would be if it was in a very clinical setting? Does that open them up to perhaps hearing a little bit more and being offloaded on more? And how do they manage that? Because that's an emotional thing. You're in someone's home and naturally you get into a conversation that you might not have done in a more sterile environment.
Absolutely. And I think by and large, everything that I have heard from that perspective has been that it's made our nurses feel so much more fulfilled and enriched by the experience, because to your point, some of these visits are 6-hour-long infusion visits. And while at a site, you might be set up in a room and the clinicians are going in and out and just checking on you, that clinician is with you for all 6 hours, talking to you about your experiences, about your life. And they really develop these bonds and these relationships, especially because we do our best to ensure consistent clinicians across all of these visits. So they're really building this relationship, and they become very invested in these participants' lives and their stories, and ensuring that they are getting the best care possible. It certainly does come with an emotional toll, especially for some rare diseases that may not have the desired outcomes. But by and large, everything we've heard from our nurses and the participants who have cycled feedback through the sites is that they found it incredibly enriching and fulfilling.
that kind of leads me to a sort of extension question here, which might be for both you and Melita, but does that present an opportunity or a threat perhaps in terms of capturing anecdotal information? Because, there's a lot of tears and tea time in that 6 hours in someone's home. Does that allow you to gather more anecdotal information that perhaps you wouldn't capture naturally? Or is there a risk that by hearing that off the record in those ways, somehow that's informing things as well? Like, there could be two sides to that. What are your thoughts on that?
So my thoughts are that I think it helps inform a holistic view of the participant's care, which I think is really critical. We ensure that as far as the data capture and the data quality, we're very specific in the questions and how the nurses are trained on that to ensure that none of that anecdotal evidence is being put into an EDC. But if
Right.
they're aware of a participant's declining state due to how they're reporting being able to play with their children or play on a playground or something like that, but maybe they're not reporting that as a change in health during adverse events, it does enable the clinician to prompt them and say, well, you did mention that you're having a little bit more difficulty playing. Do you feel like you're decreasing in this manner or this? And so I think it helps inform a more holistic view of what the participant is really going through.
Yeah, would that be your view as well there, Melita?
Yeah, because holistic is a great way to state that, because this isn't just a trial patient. This is an actual person with a life that's impacted by all aspects of their rare disease and their family too. So my experience from undertaking video consultations is that people seem to be much more relaxed in their own homes. I have seen the same children in my hospital office and the same children in their own home on the video, and they're very different children. That when they come and see me, they might be sitting bolt upright in their chair, behaving because that's what they've been told to do, whereas in their home setting, then getting up and playing with the dog and getting a toy and coming back and coming and going, much more relaxed. And I get a much more realistic view of them when I see them in their home setting. So that must translate to the mobile research setting as well.
So would it be fair to say that that's actually got the potential to improve the quality of that data capture then?
Yes.
Yeah. Okay. Were you going to add something there, Ellen? Sorry.
I would, that sometimes patients' recall when they're relaxed and at home is much more complete than what they'll report. For instance, in some rare disease where there are very specific dietary exclusions or no tobacco use, or wow, is that a box of St. John's wort tablets over there? When we take in a ConMeds, for instance, concomitant medications, it's often way more complete because we can see them on the kitchen counter. So if you're relying on recall at the site, they're thinking about the 8 other things and what happened in the train station and everything else. And it's difficult for them to recall what they ate yesterday, for instance. So we find we get a different and perhaps more complete picture of what's happening in the day-to-day of that whole person.
Yeah.
And compliance as well with the procedures. I'm thinking of children who might be a bit fed up and don't want to have their blood pressure taken right now, but there's no escape for them in the hospital setting. They have to stay in the room. Maybe they can go outside the room and come back, but it's still in the hospital setting. Whereas if they need 5 minutes in their own home just to gather themselves and go to their rooms and do something to cut off in their own space and get in, get them much more ready to do that procedure, that makes for much better data collection.
Yeah.
If you put it to that basic level.
Does that pose an further operational challenge, Stephanie, from a programming point of view? Because obviously something that you could kind of dictate is going to take this amount of time in clinic because the child's going to sit still and they're going to have it done, which could then become a little bit more fluid at home, suddenly becomes a 2-hour appointment. Does that, how do you factor that in?
I think that our budgets and contracts team, as well as Ellen's team, does a really great job of making sure there is a bit more buffer time in our visits to account for that. We typically see that, especially when a clinician is new to the participant or to the family, that maybe the child will get fed up 10 minutes in and say, all right, I need a break or need to play with some toys or something like that. And that can give the clinician time to relate to the caregiver or the guardian. And then as that clinician starts to come to the home over and over again and develop that relationship and cultivate that relationship with the participant, it does over time decrease the time that is being spent there. But we do certainly take into account that there is a little bit more buffer time in the home when we're contracting for services.
Thank you. Before we move on to kind of looking to the future, Melita, could you kind of sum up what you think in terms of decentralized trials and mobile research nurses and the way they are actually changing the landscape for clinical trials? Like, what's your kind of summary as to how that's all changing from someone who's seeing this on the ground?
Yeah, I think it's enabling, really. I think people who might otherwise have said, oh no, that's not for us, will now say yes. So it's really increasing the offering for patients with rare diseases. I think if 1 or 2 trials are successful, then other trials will come along, and that is to be encouraged. I think we need to really increase what we do for people with rare diseases. If we are diagnosing many more rare diseases now, we're diagnosing them much quicker. And so the focus has to be on treatments. And how do you develop treatments? It has to be through trials. So to really increase the number of trials that we're conducting and offering has to really think outside of the box. We can't keep doing it. You already said, Nicola, it's different in rare diseases. It's not the same clinical trial setup that we would expect for diabetes or much more common disorders. So in order to really increase what we do, we have to think outside of the box, and it has to be much more patient-centric and family-centric. So that must be mobile research.
And do you feel that's quite a universally held view, or are there professional people who are more reluctant? Are there investigators that think, no, the old way is better, and they're reluctant to move into this way of thinking? Or do you think actually everybody's really realizing that this is, this forms part of the future?
I think with assurance that the data that's being collected is accurate and it doesn't end up being a waste of time, then people are increasingly accepting this as part and parcel of a clinical trial methodology.